this case?
Yes, it is. This is kind of the more routine of the two. The other one is super interesting. This lady is interesting too. It was actually really a pleasure to work with her. She's a 31-year-old white female with Unicare insurance. She first found out about her hepatitis C diagnosis in 2014 when she was pregnant, and has never been treated. She did have a history, 1-year history of IV and intranasal drug use. And as soon as she found out she was pregnant, she stopped using drugs and has never resumed. She didn't have any other risk factors. She was, at the time I saw her, was not sure about her hepatitis A and B status. Whoops, wait, can you go back up? Yep. Wait, go a little more up. Yep, thank you. She didn't have any symptomatology related to her hepatitis C. She does have hypertension. She's had a tubal. She, in addition to her drug use, alcohol was her other drug that she used, but she has not used since 2014. She's married, and one interesting aspect of this case is that she now has 4 children. She found out when she was pregnant with her first one, and none of them have been tested for hepatitis C, so I talked to her about that. Her blood pressure is well controlled on losartan, and I think, losartan HCTZ. She is not, let's see, so if you can scroll down. I don't know why I put NA on the hepatitis A. I think that she is not immune to hep A, and that we started her. I'm pretty sure we'll see down there. She is immune by vaccination to hepatitis B. Okay, you could go down, scroll down. Very good. She was had a BMI of 26.8, and I think I put up at the top the rest of her physical was unremarkable, as they say. Her CBC was normal. I believe that her CMP was relatively normal. Glucose, kidney functions, liver functions were all normal. INR. Looks like I have the PT INR reversed there. I think I do. Maybe not. I can't tell. Anyway, her APRI was 0.24. Her child troponin is class A, and MELD score is 7. Her iron studies were within normal limits. Vitamin D was 27, so we have advised her to start replacement. Gosh, what I transcribed was not very useful here. I'll check her AFP, but it was normal. Maybe it was 3.5, but I'll double check. She's HIV negative. She is hep C genotype 3 with a viral load of 22,500, and her fibrosis score stage was F0. I didn't anticipate any problems with the losartan HCTZ and epclusa or Mavorite. She's had a tubal, as I said, so there's no problem there. Her husband is negative for hep C. I recommended that he get tested again, and that they use condoms until she gets treated, just to be on the safe side. And we started her on hep A vaccines. So if there's anything else that you all see, that would be my question. And let me just double check that. I'm going to go into her chart.
Perfect. As she checks that, does anybody have any questions following the case?
Hey, Jen, it's John. What made her wait so long?
I am not sure what made her wait so long, and what finally got her into me is I have a colleague who has been, well, as you know, many of my colleagues, but one in particular, we work in the same community in Somersville, has been really great about screening people and referring them to me. And so luckily I don't know if nobody mentioned it to her after the first time, although they would have tested her, I guess, with subsequent pregnancies. She never said, really.
Yeah, always looking for what that barrier is to care.
Yeah.
And it's perplexing when it's just, we don't know.
Yeah, I
it's
tend
true.
to, of course, my bias, I didn't verify this, but my bias is that nobody remembered to talk to her about it after, she would go through her pregnancies and then maybe she didn't have PCP. I don't know. And also that nobody was talking to her about her children.
Yeah. One other comment, actually 2 more comments. I love that like thing you have up behind your head over there, that picture. That's awesome.
Check it out.
That's amazing.
It's a local artist here in Fayetteville, Lisa Hara.
I seriously love it.
And
But
she uses river rock, to polish river rock to make that. And she used an original window from an original, I guess they call them Sears houses. So she took I didn't know you could see it on there.
anyway, expect to walk in and then I'll walk out with that. So
Okay.
hey, I'm going to be devil's advocate about suggesting condom use for the husband.
Okay.
And so I'm going to quote you some numbers.
Cool.
So what exactly is the sexual transmission risk of hepatitis C amongst heterosexual couples? And I promise this isn't my brain remembering this. This is an article I'm staring at. Can you guys all hear me okay, by the way?
Yes.
Yeah, okay. So it's from 2015, and it looked at a series of heterosexual couples in a monogamous long-term relationships without confounding exposure risks to viral co-infection or to viral infection. So in other words, no injection drug use, et cetera, and other in the partners. And they followed them for 36 months. And it turns out, it says that the maximum estimated risk attributable to sexual contact is 1.2%. And the confidence interval is anywhere from 0.2 to 2. But to put that into numbers that mean more to non-statisticians like me, it basically says your chance per sexual contact of transmission is 1 per 380,000. Okay, so how lucky are you feeling? How unlucky are you feeling? And if condoms are a barrier to intimacy, that could be, your odds are pretty good. That's the punchline. So I want to just quote that. So the overall, that's where we sort of come up with that number of saying about a 1% chance of sexual transmission per year. That's probably actually an overestimate, what we tell people. And obviously there's variables in that. There's definitely variables, depends upon particular sexual practices and the number of times you have encounters, et cetera, but remember that blood is the enemy, and blood to blood is how transmission occurs. And but I'm the world's worst infectious disease doctor because I'm endlessly expounding on becoming undetectable with HIV, and therefore saying, hey, you can abandon the condoms, and same thing from this perspective. But I open that to comment from anyone else who's more prudent than I am.
I love that. I knew the risk was low, but I didn't know statistically. I didn't look it up.
One per 200,000 to 600,000. So the average was 1 to 380,000.
Yeah, that's awesome. And I don't think anybody would object if I said, "Oh, you can dispense with the condom."
But anyway, that's my opinion.
Yep. I see why it is. I appreciate that.
I'd throw in the caveat maybe to recommend avoiding intercourse while she is on her menses.
Yes, super good.
Yeah.
That's
Good
probably
point.
a caveat I would throw in there.
Yeah.
So maybe prudish.
Prudent.
Love it. Thank you so much. Are there any other comments or questions for this case before we move on to the second? All right, you good, Jen?
Yeah.
All right. Give me one moment, please.
So the next case is super interesting, and I don't know what happened when I was trying to submit these 2 cases. I noticed a bunch of errors on this one that I that I'm about to present in the question part. So anyway, we can just quite ignore my writing. But this is a pretty interesting case. Also, a referral from my colleague who I mentioned. So this is a 46-year-old white male with, again, Unicare insurance. He, if you can just go to HPI there, Elizabeth. He thinks that he was diagnosed over 10 years ago, and he was diagnosed when he was in prison, he said, or at a clinic shortly after he got out of prison. He really thinks he got it from getting a house tattoo. He said the tattoo artist that he and his partner, wife, something like that, went to was later discovered to have infected a number of people. And but he does have a history of IV and intranasal drug use when he was in his 20s. He let's see, he says he drinks occasionally. I can't remember what his drink was, but I told him not to. And he seemed to think that he could stop. It was once a week or less. He's currently unemployed. I'm not sure what his income is from. I didn't get that far with him. He does have arthralgias. He has some ankle swelling that his PCP told him might be related to the Hep C. I wasn't sure about that, but the arthralgias, I said, yes, could be. He was not sure about his vaccination status. I thought maybe having been in prison, he might have gotten vaccinated. He has not yet had his ultrasound, and it's scheduled for the 31st, and it's an elastography. So I'm curious to see that. So he has hypertension, hypothyroidism, hypertriglyceridemia, obesity, low back pain. He is a smoker. He has been sober for 10 years, other than the alcohol I mentioned. His blood pressure is currently controlled on lisinopril and metoprolol. He is not immune to hepatitis A, and we started him on the vaccine series. He is immune to Hep B. Surface and core antibodies were positive. He was obese with a BMI of 35. And if I remember, the rest of the physical is just obesity, tattoos, and nothing. I don't think there was anything else on his physical of note. So on his CBC, his platelets were a little bit low, 128. His glucose appeared a tiny bit high, but it was non-fasting. And I think I got an A1C. We'll see in a minute. PT-INR were normal. His liver enzymes were elevated, his ALT, AST. His APRI was 1.46, child Pew class A, MELD score 6. And then what was really interesting to me, his vitamin D was way low, and we started him on replacement. His AFP was 7.3. And so I have some questions about that I didn't include in my case form. I don't know why. HIV is negative. His genotype 3, viral load of 37,000, and he is an fibrosis stage F2. You can see his other labs there. I guess I didn't do an A1C. Nope, maybe not. So I would ignore these questions here. I think that there were some big typos in there. So I'm getting the elastography to, of course, check the fibrosis, but I'm also wondering about that AFP. And should I get, what would be the appropriate imaging to follow up on that? Does elastography, would I need an ultrasound in addition to that, or would I need a CAT scan or MRI? I'm just kind of lost on this. So, or would you just repeat it? So anyway, and I didn't even put in here, but obviously I could treat him with Mavorixafor or Epclusa, and I don't think there are any contraindications with his medications. And then I would assume that yeah, we'll have to follow up on that AFP.
Thank you so much again, Jen. Really appreciate it. Any comments, questions before you go into post recommendations?
Hey, Jen, did you say the AFP was 7.3 or 73?
I think, oh, wait, let me look.
I had 7.3 on the sheet, but then I thought maybe,
I'm pretty sure it was 7.3. Am I
Oh.
wrong? Maybe?
but that's normal. Is anything
Oh.
less, you're good.
Anything less than what?
9.
Oh,
Like-
okay. For some reason, I thought that was elevated. Let me double check and make sure I didn't do.
Yeah, maybe just double check unless you have a different parameter than what our lab here does. But I'm pretty sure it's always the same.
It says 7.3 and it says above normal and it says 6.9 is our upper limit of normal.
Okay. Even still, I'd say that's pretty mildly elevated. So that's good to know because you have a different reference parameter than we do. I would suggest in this gentleman, so things that we need to think about. So fibro test, yes, was F2. That's reassuring, but you've got a patient with fairly significant transaminitis, thrombocytopenia, elevated APRI. Even with Hep C and even with advanced liver disease, sometimes that alpha theta protein, even those conditions alone, can be elevated a little bit. If it was like 100 or even like in the 40s, 30s, then I would certainly be a little bit more mindful about following that more closely. But I think as long as that AFP value, if you're trending it every 6 months for at least a while, and it's not significantly increasing, you may notice it normalizes well. I don't necessarily think you need to obtain an MRI at this point, but I definitely would recommend before you start his treatment to have that elastography back. So the elastography, that'll give you your fibrosis score, but it also performs the right upper quadrant as well. So it should give you at least, at least a first look at any kind of liver lesions or any type of abnormalities, and then you can go from there if an MRI would be warranted. The thing with him, I would maybe wait until you get that imaging back. Is just because of the fact that he's genotype 3, and even though the fibro test is optimistic, there are a lot of signs saying, hey, he's maybe cirrhotic or at least some advanced fibrosis. Remember, if you're using Epclusa, you want to make sure to do that NS5A polymorphism testing because of the reduced SVR rates. And so you could do Mavorite with him. I mean, I don't see a reason why that wouldn't be a good choice. It'd still be for 8 weeks. But just to remember that if for any reason at all that you were going to use Epclusa, for this gentleman, I probably wouldn't order that until I can secure or feel more confident that there's not cirrhosis there. And then the other thing is, again, a lot of this information that I'm giving is really going to be dependent on what his imaging shows. But if he does have any nodular changes, any evidence of cirrhosis, portal hypertension, anything like that, F3 or above, I would say that it's probably worthwhile to continue doing HCC surveillance on him every 6 months. And you can do that through ongoing right upper quadrant ultrasound or elastography. But I would probably kind of just follow him a little bit more closely because of his risk factors for liver disease and his intermittent alcohol use and the potential for this fibrosis to already be.
Right. Good. Yes, thank you. Yeah, I was more worried about him than I have been about my other people because of all that. And so that's helpful. And we'll see what the elastography shows.
Confident you'll be able to manage him well. I think that you definitely are on top of your game, and I know you'll continue to follow him more closely. But yeah, he's probably someone that even after his Hep C's treated, I'd still kind of take a peek at his liver for at least the next couple years or so and make sure that things aren't getting worse.
Right. Good. Thank you.
Thank you.
Thank you so much. Anything else with that case? Jen, are you feeling good?
That is it. Thanks.
Of course, my pleasure. And thank you guys so much for all your feedback as always. All right, Dr. Gilfus, we're ready for you. I gave you capabilities of sharing your screen.
Cool. Am I finishing up the Lyme talk?
Yes.
Oh, good, because that's what I'm ready to do. Because
That's awesome. That's perfect. And then send those slides over when they're today at some point when you get a
I'm gonna
chance.
have to walk them over or something because it's such a huge PowerPoint. So can you guys see that okay?
Yes.
All right. You know what? Actually, I'm gonna exit out of that. What can you guys see?
The whole slideshow with
Okay,
like
sorry, I'm so
Oh, it's
incompetent
okay.
at this. So basically, I was going to finish up the controversy component of Lyme, but just as a review, we talked about the history, how this was, something that's been here since the late 70s, early 80s. Talk about the expanding tick vector with the Ixodes scapularis and its co-infection microbes of Anaplasma and Babesia. We talked about the microbiology of the spirochete and the fact that it's a microbe that causes clinical manifestations through primarily through immunologic mechanisms rather than protein production, toxin production, etc. So it's your immune system fighting the infection that causes the trouble for the most part. We talked about the varied clinical manifestations that occur in stages from emigrans to dissemination to sort of late manifestations. And importantly, we stressed the fact that Lyme disease doesn't kill and it goes away. So that's important factoids to keep in your mind. That doesn't mean anyone wants it. It can make you feel terrible for a decade or longer. So we talked about how to diagnose it, and treatment was simplified in general to give doxy whenever possible. And prevention, we talked about, obviously tick bite prevention with DEET on your skin and permethrin on your clothes. We talked about if you do find an Ixodes embedded, to give doxycycline 200 milligrams afterwards, since we live in an endemic area. And we talked about buying guinea fowl for your yard because everyone needs some. So I'm gonna reach onto the part of Lyme disease that's probably the most important, and that's the controversy part. And I'll blow up my thing. Here we go. All right. So what's the controversy with Lyme? What's the issue? Why is it a word that makes us cringe as providers and feel desperate as patients? And it's because the medical community has to say three words that we hate to say, and that's we don't know. We don't understand everything about Lyme disease. So that's a true statement. I've become much more empathetic and sympathetic for patients over the years after having seen too many, innumerable, go through this. I hope to give you some objective evidence of what we need to do to go forward so that we don't disenfranchise our patients, number one, or lead them to areas that could cause harm. So there is this concept that is absolutely real called post-treatment Lyme disease syndromes. It is not chronic Lyme is what patients will often call it, but I would encourage you not to use that word. I would encourage you to use post-treatment Lyme disease syndrome, and that is a thing. So what is it? It's basically, I want to dissect these words. So it's non-specific, but it is characteristic. Okay, so the characteristics parts is I have headaches and fatigue, musculoskeletal discomfort, brain fog. Okay, do these sound unique at all to Lyme? They don't. They sound like long COVID. They sound like post-EBV. It sounds like a lot of other syndromes. Sounds like non-infectious syndromes, fibromyalgia, etc. The second word in here is the word subjective. And this terminology is not to minimize the symptoms at all. I sort of despise the word subjective from that perspective. It almost is like discounting it. And it's not the intent. The intent is to separate it from those symptoms that are objective on physical exam or laboratory. So for example, arthritis, genuine swollen joint would be an objective sign and symptom. A subjective sign or symptom would be musculoskeletal pain. Okay, So this post-Lyme disease patients is stuff we can't find on physical exam, can't see on labs, but patients experience it, and it can persist for a long time after treatment of Lyme. Okay, and what percentage of people? So even people treated, so this is an example of patients treated at the E-migrans phase, which is how we'd love to treat all Lyme, because that's catching it early. That's catching it in the supposed non-disseminated phase or early phase. You can see people still can feel terrible. A good percentage of people can still feel awful, weeks to months to even, I always tell people maybe 20% of people can still feel lousy at a year. And I think the most important part is include that in your education up front, and include the affirmation that these symptoms that people experience are consistent with the diagnosis. Okay, so affirmation and education, and education that we don't have the great understanding of where these symptoms come from. So I always acknowledge that. I'm saying we don't know. We have hypotheses. The hypotheses is this is a slow resolution of the inflammatory process. The immune system is your friend. It helps beat this infection, but the immune system also can be problematic insofar as it induces these symptoms. What we don't have is evidence that there's active ongoing infection in patients who only have these subjective symptoms. And I think that's really important. So remember, you can have active ongoing infection that requires more additional antibiotics if you have somebody who has, say, ongoing documented radiculoneuropathy or ongoing oligoarthritis, genuine inflammatory arthritis. Those are situations where the bug might warrant additional antibacterial therapy. But what do we do for patients who are experiencing post-Lyme disease syndrome? First, I put this slide up and I leave it in here as a memoir of my own bad thinking. So back in 2010-ish, I really wasn't sure if post-Lyme disease syndrome existed. There are a lot of articles that support that concept and simply call it anchoring bias. And they say, you know, we link too many symptoms. We as patients, we as providers link too many patients to Lyme disease after we've experienced it. I've actually disagree with anchoring bias as the answer for post-treatment Lyme. Too many of my patients experience this for me to simply say it's not real. So I don't think that's real at all. But do recognize that you have to make sure that your patient actually did have Lyme disease. So Dr. Steer is the grandfather of Lyme disease, and I like this article in JAMA. The most common reason for lack of response to antibiotic therapy was misdiagnosis. Okay, so really, really important. If you have somebody that didn't get better from Lyme disease, whatever their clinical manifestations may have been, you know, the most common explanation for that is we got the wrong diagnosis. So revisit that serology, revisit that story, make sure the diagnosis was accurate. Okay. What do we have to do to label somebody as a post-Lyme disease syndrome? First of all, you need to have documented Lyme disease. And again, that usually means seropositive. Only exception would be if you diagnose somebody with a concrete 100% confident E-migrans rash. And even in those scenarios, it's worth trying to confirm with serology. But remember, sometimes in those patients, if you treat them early on, it will abort seroconversion, but that's extraordinarily rare. So before you label somebody, make sure they've had Lyme. They've had resolution of their objective manifestation. So you no longer see that swollen joint, their Bell's palsy is better, and blah, blah, blah. Okay. And duration, you don't want to label them this until it's been a while. So really onset of subjective symptoms within reasonable proximity to the diagnosis of Lyme and lasting a reasonable proximity after treatment. Okay. And again, make sure symptoms are consistent, which are that musculoskeletal myalgias, arthralgias, brain fog, fatigue. And really excluding people as any other diagnosis or objective abnormalities that might lead you back to saying this is either an active manifestation of Lyme or potentially a different diagnosis. So what we do know about Lyme, and the issue with it is we don't know what to do for people. So, and this is what I'll explain to people. This is part of the affirmation that yes, we understand what you're experiencing is real. Educate that that this isn't all in your mind. This is what you're experiencing, and we accept this as reality. Unfortunately, what I don't have is any data of what to do going forward, and it's that vacuum of not having an action arm that leads to trouble. Okay, and I'll talk about that. But so what we do know doesn't work is ongoing and persistent antibacterials. And so there have been multiple placebo-controlled studies, which is, kind of our gold standard that we use, at least in right now in medicine. And it looks like more antibiotics doesn't help. Placebo-controlled is as good as you can get. So we really, unfortunately, we need to understand the mechanisms whereby people have persistent symptoms, and I wish we had something to offer them. But when the medical science reaches that point is what I'd say opportunity just ahead for patients to seek out all their answers. Now, a lot of times if we do our job with affirmation and education, they won't go elsewhere. I often tell them you're going to get better in about a year or 6 months if you spend a lot of money and go see a lot of other doctors, or you're going to get better in 6 months to a year if you do nothing but wait. And but if you do decide to go seek out other treatments, et cetera, keep me posted so that I can monitor you for safety, et cetera. But there's a couple other groups that patients might fall into, and I do not at all want to give off a cynicism or at all. It's just this, I don't know enough about these to say if they're helpful or not, but as long as we keep our patients safe, if they're pursuing these alternative medical avenues, that's kind of where I sit now in 2023. Be aware that besides the fact I've been taking care of patients with Lyme disease for about 15 years now, I am not considered a Lyme literate medical doctor. So you probably shouldn't even listen to me giving this talk because I'm not, according to the internet, Lyme literate. What is the belief system of a Lyme literate doctor? A Lyme literate doctor believes that, number one, basically any complaint that you come in with subjectively might be attributable to Lyme, number one. Number two, that symptoms are from active infection. Active infection either from Lyme or some co-infection, which has potentially been found in the Ixodes tick or some other tick or some other animal in the environment somewhere at some time. So the punchline is it's a bit of magical thinking about the transmission of other microbes to you, that the diagnosis can be clinically made and that it cannot be easily treated. So in other words, don't trust the lab tests unless they're positive. And we can't really treat this easily as opposed, and that's completely, most of this is completely different than the dogma that I was expounding on in the first couple parts of this talk, where I said, Lyme, use precision of language. It can do things, it can do a lot of different things during its disseminated phase, but they're really, we can put words on them. We can put rheumatologic descriptions or neurologic descriptions on those symptoms. And that most of our persistent symptoms come from not active infection, but sort of post-immunologic sequelae. And that we definitely need to be able to diagnose this objectively, and that we can treat this, and in fact, it will go away and not kill you. So that's the difference between a Lyme literate doc's teaching and what I teach. The paradox of Lyme literate docs is that we accept the fact that there's the supposition is that there's these few remaining spirochetes that are hidden from the host immune system, so they can't be detected. You can't ever rule them out. You just have to assume they're there. But at the same time, we know that these spirochetes lack toxin production, and they lack an ability to actually do a lot of the pathophysiology that they're blamed for. So it's really it's sort of a logic paradox that never passes the test for me. Sometimes the Lyme literate docs will use a Lyme specialty labs, and in general they're the same test. They tend to be the same test, but they might have more liberal reporting criteria. And the term chronic Lyme disease has really been invented by the internet and popular culture and Lyme literate providers to explain to people who experience symptoms similar to post-treatment Lyme, but never have had positive Lyme testing. I do not advocate the use of the word. I think it's an avenue towards misdiagnosis and false attribution. So don't go to chronic Lyme disease. Feel free to use post-treatment. Now, this is an example of one of the websites that patients end up on who are sort of, if we don't spend the time to educate them on why they still feel like crap after they had their Lyme treated, they might end up at one of these fine Lyme literate doctor places. I put my name in there to make sure I'm not on there. And I love the fact there's a donate sign. Beware of anybody who's giving you advice and then asking for money. Although technically, I guess I do that, but I don't try to. I wish I did my job for free, honestly. So what might these other docs, what might the Lyme literate doctor have in their armamentarium? Unusual antibacterials. And I'm going to show you some lists of some patients that have been on stuff. So first generation cephalosporins are the beta-lactam that do not treat spirochetes well. So basically any other beta-lactam in the world does, but not first generation cephs like Keflex. They might get, any of these traditional antibacterials, antimycobacterial agents. Conceptually, I'm not even sure what we're doing. I think we're looking at sort of intracellular or biofilm versions of bugs, which we have not proven exist. I'm not sure why they sometimes give antivirals, antimalarials, antifungals, intravenous IgG, hyperbaric oxygen, irradiate the blood either with electromagnetism or UV light. Spirochetes, this is kind of interesting. Spirochetes genuinely don't like warm temperatures. And it was an old school treatment for syphilis to give somebody malaria. So you can kill you can kill syphilis with high fevers. And so there have been cases in the United States of people importing Plasmodium pathogens to give to patients with Lyme disease to treat their Lyme. That's a bad idea. Giving them something that will go away and not kill them with something that can kill them. Now, here's an example of one of my patients. So this lady was awesome. I loved her. She was highly intelligent, but didn't feel good. She had Lyme disease and did not feel well after treatment. And she wrote out a list of everything that she had done over the years. So doxy, ceftin, doxy, zithro, rifampin, doxy, Bactrim, artemisinin. That's an antimalarial that we can't even get when we need it. Mepron, Flagyl, Zithromax, Lariam. That's another antimalarial. Rifampin. By the way, her chief complaint over this whole time period is her bowels felt messed up. By the way, and I was like, man, and I love this. Gave up on meds, but the logic and again, a beautiful brain on this lady. But talking to when she talked to her Lyme literate medical doctor, when she was having a good day, it meant the antibiotics were working. When she was having a bad day, it meant the antibiotics were working because she was so-called herxing. This is a term. If you remember, I talked about treatment of spirochetes. When you have excessive numbers of them in your body, you can have what's almost like a bug lysis syndrome. It happens in the first 24 hours of treatment. It does not happen repeatedly over time. So this concept of herxing is a biologic phenomenon adopted by the Lyme literate doctors to explain when people are not feeling good, to encourage that their antibiotics are doing them good. It is a bunch of, I can't say the word on the internet. What happens when you stop getting better? Add more different antibiotics as evidenced by this thing. So does this sound like good medicine? Well, I'm going to even hopefully scare you more. So some of these treatments have literally harmed people and killed people. And so there's cost. And actually there's medication toxicities, numerous case examples of issues with of causing hepatotoxicity from these long-term antimicrobials, bad drug rashes, C. diff, line infections. People have died. So I have these two articles over here of people who have literally died from long-term antibiotic therapy related consequences. And I think the scariest thing of all is the missed diagnoses. The CDC has a bunch of case examples of people who have had diseases that could have otherwise been diagnosed, but everything in the world was being attributed to Lyme. So shouldn't the medical community do something about this? Well, we sort of have, the collective we, and that's IDSA, the infectious disease people got together with the rheumatology people and the neurology people, and they put out great guidelines. And they've been updated since, but they've been out for a while. Society responded by protesting those guidelines and saying that they're not recognizing their chronic Lyme, their post-treatment Lyme. They're cutting them off from these Lyme literate doctors. So the government responded how? The government responded actually by representing the people, interestingly enough. So this fella's still in the Senate and basically sued the IDSA's guidelines and said, we need to recognize these Lyme literate medical doctors as valid. And that's sort of where the laws are sitting right now. These advocacy groups are brilliant. So if you look at this International Lyme and Associated Disease Studies, their guidelines, they put out their own guidelines. And honestly, if I was a patient reading them, they're way better. They say way better from like a non-medical perspective. They say, hey, we're going to individualize your approach. We're going to use clinical judgment, not silly labs and objective evidence. We're going to emphasize your quality of life. You know, it's very attractive. It's just unfortunately not a good idea. So anyway, even our state laws here protect doctors who decide to practice in this manner. So if I decided to put a PICC line in somebody and give them a year's worth of ceftriaxone because I actually believed I was helping, I would be protected if they died from a fungal line infection. Yeah, so unfortunately, it's a disease that's politicized from that perspective. And I genuinely feel like it comes down to the fact that we don't spend enough time talking about that affirmation and education on day one, and we leave patients to solve their own problems, and they find answers on the internet, which lead them to do things. So why is it Lyme disease? You know, when I first started learning about Lyme, I thought it would be an easy answer. I'm like, why is Lyme disease the bug that people cling on to? Why isn't it syphilis? Why aren't people into their syphilis? And I think it ultimately comes down to the mechanism of transmission is Americana. You know, how'd you get your Lyme, man? Well, I was out hoeing my garden with my dog and a tick bit me. Here we go. You know, I didn't have any bad habits or activities. I was just doing what I should do, and I got this thing. Now, it's also a spirochete. We know spirochetes are an unfortunate group of organisms that can cause chronic illness. We know that from neurosyphilis and long-term untreated syphilis, et cetera. And it is a bit of a stealth pathogen, but it's not magic. It doesn't have an ability to evade things that are trying to kill it, like antibacterials. We use medically ambiguous terms, which I think we should fight against, and try to label patients' symptoms specifically with terminology. And if we, and again, I'm not very good at that. So I use subspecialists a lot. I use neurologists and rheumatologists to help me put patients subjective into words a lot. And of course, then there's the dirty financial gain part that people have to a lot of times pay for all these alternative medical approaches, and it makes some people money. Fear fear ignorance in the internet. And I would add one more, and lack of education. So we can do that. We can fight that. I encourage people, if you read something online that disagrees with anything that I've told you, give me a call and let me take a swing at it and see if I can help you out, rather than going down a rabbit hole that Google leads you to. And there we go. That's the last of my Lyme stuff. And I hope you guys have some cases you can present to us. And I would love to try to help. Thanks for your attention.
Thank you so much, Dr. Gilfus. Yes, please bring cases in. This is a very, interesting topic, and really appreciate it. And we're seeing more prevalent cases every day, I think, and every year. Does anybody have any questions for Dr. Gilfus or comments?
I just want to say this is just fascinating to me, the presentation, and I would love for you to give that presentation to our other members of the PCA and FQHCs, because I think that is something that, awareness, and I think you did a great job at explaining it.
Oh, thanks. I would love to get that message out there, and it's a PowerPoint I already have made, so that already makes my willingness to say yes there. My only thing I don't like about talks is making a PowerPoint, so it's already pre-made. I'll talk every day about it if you want. Thank you. Thanks for the invite. I appreciate it.
Dr. Gilfus, thanks for the whole series, and including today. I think it's really helpful to think about and talk about the controversy and to learn about post-treatment Lyme. I would add to your list and it reminds me of post-acute sequelae of COVID, that I think that when people feel really lousy and they're not and they can't get answers, that tends to drive them to both the internet and to people who say they have answers, and that they're, because we don't know, I think, and because people, I think, are not, because I would propose that the medical community isn't able to be supportive and articulate that we don't know, that people feel disenfranchised when they know they don't feel well. And so I think your message throughout this whole series of how to communicate with people is really well done and important for Lyme and for things like, post-COVID, because I think there's a parallel there with people feeling not validated in their experience of their body.
Beautifully said. Yeah, I think that validation component followed by education is literally everything. When I honestly, and Kaylee sat with me in some of these patients, I don't do anything when I see a patient with Lyme. They've 99% been treated. Only thing I bring to the table is about a half hour to 45 minutes of talking. And it's that education component. And, it's the luxury of being a university-based doc. I don't even know what an RVU is. So, it's a beautiful thing, but you're right on. And same approach from, people who complain of symptoms from Hep C. We can't always objectify them, but man, we know they're real. And post-COVID and a whole bunch of other things. Yeah, validation, affirmation. Last thing we ever want to do is leave them unsatisfied. And, just a few comments on the Lyme literate medical doctors. I've known a few of them. I actually have one who is a friend. They are not bad people. They have a different belief system, and they think they're doing right. I think the large majority of them do. And I don't think they're there for financial gain. I think that they've had an experience and they found disenfranchised with the fact that we as the medical community can't answer the pathophysiology and treatment questions. So they're not bad people. Just beware to try to help your patients avoid harm and let them know that they're going to get better, even if they don't spend a lot of money and do a lot of weird things.
Thank you so much. Go ahead,
I
Dr.
think it's hard to tell people that something's going to take a year to get better.
You are so correct.
I mean, you try it and then they go down shoot, I had that experience in my own family several years ago. My mother broke some ribs. I said, you're going to hurt for 3 months. She didn't like that. She went down the street to see the orthopedic doctor who told her she was going to hurt for 6 months. But,
Yeah.
we all want things to be better instantly. And,
and doctors aren't patient either. We want people to get better, and when they're not, we think that we did something wrong, or there's got to be. But yeah, there's patients aren't patient, doctors aren't patient, humans aren't patient. But that's honestly part of the message I tell people. If they're in on that, they sort of can gut check. They're like, you know what, aha. And again, paint that picture of big picture reassaying how you're doing. So in May, am I doing better than I was in February? Oh yeah, I don't feel perfect yet, but I am better than I was. So and so on and so forth. But you're so right on, Dr. Rexroad. I don't know a fix for that one.
My family doesn't like it. Then I tell them a cold takes 7 to 10 days. Every time I say that. I don't have a case to present for feedback, but I thought you might be interested in this story that I have of a friend who was really suffering for months and months from pain. I'll just say from pain, without getting into the details. This past summer, and his wonderful primary care provider, this was in Monroe County, ultimately ordered a Lyme panel after a whole lot of other workup because the pain was so difficult to understand. And he was actually had this radicular neuritis.
Yes.
And which I had never heard of before then. And then until I heard your talk 2 weeks ago or whenever that was. And so he has improved dramatically with treatment. He was put on doxy, and dramatically, but slowly, right? And so I've been telling him about your talks, and particularly about this concept of it's not the toxins, it's the immune response, and it just takes time. But it's also to me was a really astounding example of how devastating the consequences can be, and to think of it in endemic areas.
That's beautifully said. And you know, it's a disease I wouldn't wish on anyone. It's miserable. And people really do feel awful. It's genuinely, I probably think about it every time I go outside, which is a bit paranoid. But we have to be. You know, there are ticks all winter long now, and so on and so forth. So yeah, validation. That's all the validation. It's real. It's miserable. And you're right on. I've seen it take healthy young athletes and make them unable to do much for a little while. But the good news is, it's going to get better. So, and that's a great example. Thank you, Jeff, for including that.
Thank you so much. All right, we have a little time left. If you have any other questions, please feel free, but I'll put up that poll before you go. And my only announcements, the next time that we'll meet will be April 13th with Kaylee discussing co-infection. So really appreciate all of you, and just give me one moment. Can everyone see this? Yeah, okay.